Welcome back to Season 3 of the Miscarriage Rebellion. Today we have the wonderful Professor William Ledger, or Bill as I know you now. Bill has been a long-time supporter of pink elephants from the very early days. And one of the things that we're doing with this series is taking a moment in time to stop and to reflect on those that have made a difference to pink elephants, that have showed up for us so that we can show up for you, our community, who are grieving the loss of their baby or are facing fertility challenges and need a support organisation like Pink Elephants. I hope you'll hear today from Bill's experience with pink elephants, just how profound this first meeting I had with Bill was for us. Yeah. Welcome, Bill.
Thank you. It's good to be here.
Awesome. Really, really excited to have you here. I think I will literally go back to 2017, very early days of Pink Elephants. We'd just been registered as a charity. We'd just built the website. Yep. We had the resources, and we were now working out, well, how could women find us? How could we build some referral pathways from hospitals? And at that time, you were the head of Obs and Gyns at the Royal Hospital for Women within Sydney here in Randwick. That was my local hospital where I went through all of my experiences, all of my babies. And I reached out and I said, can I have a meeting? I want to talk about this thing that we're building and what we're doing. And you were gracious enough to accept that.
Sure, it's amazing. It's almost 10 years ago.
I know.
The time has flown past. By that time, I'd been working in Australia for 7 years and was the professor of O&G at UNSW and, as you say, the head at the Royal Hospital for Women. Royal Hospital for Women has a big EPAS, Early Pregnancy Advisory Service, and it looks after anything up to 10 or 12 women every single day who are bleeding in early pregnancy, maybe having miscarriage, and all of the follow-on from that. And I'd been impressed by the clinical quality of what we were doing there. It was fairly quick, which is important, and accessible and free. But the problem was that it was a clinical service in the acute setting. So someone would come, we've done the scan, we've done the blood test, really sorry, pregnancy's not progressing, we'll organise the D&C or we'll do the medical management, and after that, goodbye. And that hurt. And because I was nominally in charge of it, I felt from my sort of lofty position that really there was a big gap. Because I know from my own experience, and I know from experience of over 30 years in acute gynaecology, that there's a huge hurt. And people need support and follow-up and often long-term help to get over a disaster. And our problem in medicine is because we see those disasters 10 times every day, you become, I don't know, just a bit immune to the tragedy, because if you don't, you can't actually do your work. You can't share the deep hurt with every single person. You know, you have to go home at night and get on with things. So I think I was kind of in a very receptive frame of mind when you came to see me, totally out of the blue. You know, who are these people? What's this about? You did a presentation which was really good, and it just struck a chord. And I think something happened between us in that meeting where we're just on the same wavelength. And no, I was more than happy to put my shoulder behind the project. It was early. It was struggling for funding. It needed to just have the opportunity to be known about. And it just went from there to where you are today. And can I say to you, I'm super proud to have just done a little bit, you know, just with a little bit of leverage, to have helped it make what it is. No, it's a real achievement.
And I want everyone to hear how huge that was for us in that moment. There was Gabby and I. I finally got Gabby on the podcast. She's going to be on another episode.
Good.
That's taken 3 series to get to convince her. And it was the very early days where we knew we'd created something that women wanted. We knew that it would make a difference. We had been holding focus groups. We'd been testing. This all built the presentation we brought to you. It wasn't just about mine and Gabby's experience. This was from the beginning about founding something that could make a profound impact to those who need it most. And so to come and to sit with you, who the head of Obs and Gyns at one of the largest tertiary hospitals, was really, really confronting and hard. But you were amazing.
I think you were a bit shaky for the first 2 or 3 minutes, and then you realised that actually the dragon didn't breathe fire.
No, you were a normal person.
And it was fine.
There was a fear.
A normal person that really liked what you had to offer.
Yeah.
I could see just from my own experience that there was a big gap that this was going to fill. And I just almost from day one felt, yeah, this has a really good chance of being successful. And you've found so many different areas where you can help people from that first concept. It just blossomed. And I still now, I mean, I run mostly a fertility practice.
Yeah.
I see a lot of miscarriage. And everybody I see gets your web link and I send them along.
And I couldn't be prouder that we can do that now, that there is somewhere to send these women and their families now and say, hey, this is not something you have to deal with on your own. It's not isolation. Yes, it is common, but we know it's your baby. Like, here's where you go, here's where support. And what kind of difference does that make?
Well, I was going to say, if you go back further, when I was, I don't know, a trainee or a new consultant, if a woman had a miscarriage, it wasn't spoken of. No, I mean, go back to when I was a young doctor. If a woman had a miscarriage, it wasn't talked about. Even within the family, it wasn't spoken of. And it was very much something that was seen as she was to blame.
Yes.
You know, you did something wrong. And I don't know, the guilt and the sense of distress and disaster that caused was awful. And we saw it as doctors because often we were the only people that these folks could talk to. And it wasn't an unusual thing. It was almost universal. Oh, no, we don't talk about that sort of thing. And thankfully, in our time, you know, the lid has come off. People can discuss these things.
Yeah.
They can talk about their endometriosis, their perimenopause, their PCOS, their infertility, their miscarriage problems, their pregnancy problems, honestly and openly.
So we've come a long way in terms of being able to share women's health and talk about the experience. And we're seeing that society is moving from it's common, it's nature's way, at least it happened early. It's not quite there yet. We still know many women who hear those like feedback today, and that's not okay. But you've seen a big change in the time that you've been in this space.
Maybe in two places. Firstly, I think the medical profession are much, much better. A lot more doctors are women these days. That's a big change in my time. And that's been so helpful when, you know, asking doctors to deal with problems in women's health in the broader spectrum, because these are people that live that experience. And that's been a big thing. But also the fact that in society, people are now free to talk about their experience. I don't think there is a stigma.
No.
People understand that the miscarriage is a biological thing. It's not because you did something naughty in your life. And all of that, I think, is disappearing quite fast. So there's an openness now. And when someone has been through the disaster, there can be sympathy and some compassion. And people understand more. And I think the language is changing as well. You know, thank heaven. And I almost regret mentioning this. But when someone in my time, when I was young, had a miscarriage that didn't complete, it was called a missed abortion. And I think we've got rid of that language now. I hope you don't hear it around the country.
No.
And it just is one little piece of evidence about how things have changed for the better.
100%. And there was things like spontaneous abortion.
Oh, yes.
And labelling it the same.
Yes.
And it isn't the same.
It was just wrong, you know. And it wasn't in... People were not being malicious. They just didn't think. And by raising awareness, the work that you've done is making people think more and be more respectful and careful in how they use language and how they react to people.
And I think language is one area, and I do see that's changing. And I'm really hopeful that the awareness raising around that. But it brings me also to think about the experience of a woman in a hospital and how important it is we consider the settings that woman is in. So things like, we know within some rural and regional settings, they might have less space, for want of a better word, but we still hear of women waking up on maternity wards after the loss of her baby. And we still hear of women waiting in waiting rooms with other women that are heavily pregnant. And that's incredibly confronting.
That, I think, is one of the biggest problems. And the problem is just underfunding of the public hospital system across every state. And it is state-based, but I don't think there's any examples where it's done well. Not because people don't want to do it, and not because there are really good examples around the world of how it can be done better. But even at Royal Hospital for Women, we don't have the resource. to make it as comfortable and as appropriate as it could be. And it's a constant fight for funding, as you know from your trying to get to where you are now. Some funds have become available. We're doing better with endometriosis at the moment. Menopause at the moment is better funded. But there's still a big gap in the, just like you say, the structure, the environment, you know, and plenty of examples of how you can make an early pregnancy assessment service really smooth and separate and gentle.
Yeah, which you have done at the Royal. Like there
We
is
do our
separate.
best.
Yeah.
It's good, but my word, with a better environment, put the concrete in different places,
Oh,
it could
100%.
be better.
Yes, definitely. There's still kind of going past the baby shops and
Yes, I know.
that
I know.
area, right? And I understand the funding restriction, I truly do, and we've championed for a long time, but we'll continue to push and agitate there, and it will change, but the raising awareness is a big part of it, right? Yeah, we can see that. Tell me about your work with the IVF clinic that you worked on, because I think it's phenomenal.
It is interesting moving to a totally new health system and a new hospital, which I did back in 2010, 2011.
Yeah.
Because you kind of parachute into something that's been going a long time. And as an outsider, you see gaps that maybe the people that have worked within it for all of their lives don't perceive. And I come to Sydney from working in NHS, National Health Service, in Sheffield in the UK, which, as you know, is a working class city, not with a lot of money, but with some of the nicest people in the world.
Yeah.
And I was able in Sheffield to put an IVF service into the big public hospital. And it took a lot of effort and 10 years, but when I left, it was functional and running well. I get to Royal Hospital for Women in Sydney, which again is a public hospital trying to serve the needs of everybody. And not everybody in eastern suburbs of Sydney has a lot of money. There's a lot of people.
There's a disparity, right?
A huge disparity. People on low income who are just as entitled to have a family as people on high income. Maybe it's a bit naughty to say this, but I often think that the people on low income make better parents than the ones on high income. They sometimes have more time with their children, but let's not worry too much. And there was no facility. There was very good IVF in Sydney and across Australia for people who could afford it.
Yes.
And Medicare made it affordable for people on a medium income, say. But the public hospital had everything else trying to cover all the needs of women's health, except no IVF.
Yeah.
And I started to ask, why don't we have IVF? This is something that I know how to do, and I've seen it work really well. Oh, well, we don't think we really need it. The private sector picks it up. So anyway, it seemed to me there was a gap. And the other thing that came along, which was a huge need, was this whole new specialty of onco-fertility, because the cancer doctors in the developed countries like Australia are helping young people with cancer survive long-term in big numbers.
Yeah.
If your youngster gets a leukemia or a lymphoma or a solid tumour, heaven forbid, but if they do, in 2026, their chance of long-term survival and long-term health is pretty good.
Yeah.
Which wasn't the case even 30 years ago. The chemotherapy, the radiotherapy destroys fertility. In boys, in girls, young men, young women, it just is totally causing them to be totally infertile. So the idea came out of Europe, why aren't we freezing eggs or sperm for these youngsters before they have the chemo? Because yes, they're a person with cancer, but the reproductive system still works.
Yes.
And then they've got a fallback in the future. And thankfully that got a lot of leverage. Politicians like it. Brad Hazard was the health minister in the old government in New South Wales. Lovely man, he's a grandfather, and he got it straight away.
Yeah.
And again, with a lot of help from a lot of people, we managed to fundraise and build what we've called the Fertility Research Centre at the Royal Hospital for Women. We ended up getting nominally about 8 million from government of New South Wales to make it happen.
Incredible.
Well, it is a bit incredible. But then, of course, Victoria, being Victoria, gave about 60 million to the people there.
A little bit of competition.
So now the Royal Women's in Melbourne has a splendid service, which is bigger than ours, but ours is still pretty good. I know that Brisbane are starting to run an onco-fertility, and the other states will be looking because it was a real unmet need.
Yeah.
Coming from that, we built the IVF thing specifically to try and do egg and embryo freezing and sperm freezing for these young folks with cancer. But then we could help people with infertility, and we could help people with genetic problems that can be treated in these ways, at low cost and in the public sector, where a lot of people feel more comfortable.
Yes.
Not everybody likes the kind of, glamorous, you feel like you're in an Oxford Street fashion shop sometimes. People like the healthcare to come out of a hospital sometimes.
Yeah,
so
totally.
It's
There's
been
reassurance.
a success. It has been a success.
100%. And I also know people, I won't name them, but I know people that have welcomed babies thanks to your work there. And that's not something small. That's huge, profound.
Yeah.
They have a baby because of the work that you did there. I love it. I want to also talk about, you've practiced for 30 years and you've seen all of these experiences from loss to IVF. And yet miscarriage is often kind of viewed as something that happens as a moment in time.
Yeah.
It's an early loss, so therefore you should only grieve for this amount of time. But as an obs and gyn, what did you see from our community when they were pregnant again after loss?
Oh, that's a very good question, because I don't think most people who've experienced a miscarriage ever recover completely. It's like any bereavement. We've all lost people who we love.
Yes.
And you function, you work, you carry on with life. Of course you do. And life can be lived and enjoyed, but there's always a small part of you that misses them. And I don't think the loss is fundamentally different, whether it's losing an adult relative or losing someone who was going to become part of your family and never made it. I think the hurt stays.
Yeah.
And we're learning that more, and we're making it an honest and acceptable thing for people to carry, and we help them.
Yeah, absolutely.
And that, I think, has been one of the big changes, like you say, over the past few years, is that now is accepted, whereas in the past it wasn't.
Yeah, absolutely. There was this pervasive acceptance that it happened early, therefore you get over it quickly,
yes,
right?
Get over it quickly.
But what we see is women and their partners with huge amount of anxiety carrying through a subsequent pregnancy.
Yes.
Things like future scans, things like all those milestones. Yeah.
Oh, no, the whole pregnancy experience is in no way joyous, because the expectation something's going to go wrong is there. Well, you have to be careful of dad jokes at my age, but one of the things I say to people quite a lot is, you're going to worry about this child until it gets into uni.
Yeah.
They do. It's different when you've had the loss. And, everybody cherishes their children, but you cherish that child, sometimes over-cherish them because they're so important and so special. And people reference back to, oh, yeah, you'd have had an older brother or sister who was 2 years older than you, and it didn't happen. And that doesn't go away.
Yeah. My 4-year-old still very much sleeps in my bed, pretty much on my head. And I remember how generous you were during COVID, and you were the one that gave me the scan, the early dating scan for him. I remember I was so nervous. I was terrified. I didn't trust anyone. I wouldn't go anywhere. And you gave me so much empathy, and you knew what I did as well. So there was an element of that for me that was a concern, that I didn't want to just walk in and everyone know. And you were really accommodating, and you used those words to me. You're going to worry about this child until she's in university. And I can confirm that's 100% truth.
I know.
Because I do.
Yes. And that's the humanity of people, and it makes the bond stronger. I think it's not a bad thing or a good thing. It's just a thing. Yeah. And it's part of the life that we all lead. You know it. So many people experience miscarriage. It's such a common thing. So the emotional thing that we're talking about is universal. Everybody's been there, and everybody has their own story and their own story to tell.
And that's what Pink Elephant's growth and success has been a huge part of, because there was a real need, and we tapped into that and then delivered the support that they deserved all along. And if this had been done 10 years earlier, it would have grown then. So I think there's a huge part there. I think that's around like the narrative, the shifts in language, the shifts in hospital systems. I also, maybe it's worthwhile having a little bit of a chat around, like, we now potentially can start to understand more about why miscarriages happen through genetics in the future. And there's also now, I'm very wary of this, because there's no magic pill, there is no magic fix, people need to hear that. But there is more discussions around things like progesterone.
Oh, yeah.
Like 10 years
Yes.
ago, no, you don't
Yes.
need that. No,
Yeah.
now.
Yeah.
So I don't know whether you want to talk a little bit from a medical perspective.
I still think there's a ways to go. Okay,
Huge.
so yes, if the woman is older when she becomes pregnant, the chance of a genetic problem is greater, and so the majority of miscarriages in that older age group, at least we can explain. Another thing that's changed over the last 2 decades, we now almost routinely test the chromosomes of a miscarried pregnancy, so that person can know at least why it went wrong. And I think that's really comforting that,
Yeah.
know, A, there was a genetic cause, it's not something that you did, and B, it's not recurrent.
No.
It's just a sporadic accident of nature, which isn't going to happen again. But that's still only the minority of miscarriages for most young women who are pregnant in their 20s and early 30s. And it's very difficult even now to put a finger on the reason why those pregnancies are lost if the genetics are normal.
Yes.
And the flip side of checking the genetics is when the report is normal, I have a heart-sink moment because I'm not going to give her or him as the partner an explanation. So that's a problem. Progesterone, yes, there are big clinical trials now. There's a good evidence base that says that if you've lost pregnancy before and you have bleeding in the current pregnancy, progesterone can help.
Yeah.
But it's not Harry Potter magic.
No, and we need to hear that, right?
I know. Every pregnant woman does not need to use progesterone.
Yes.
It's not helpful, and it's just using medicine when medicine's not necessary. And we try hard to educate our GPs because they're often the first point of contact. And something like an EPAS will know how this works. So if you're eligible for progesterone, if it'll help, you'll get it. And there's a big push to get it onto the PBS, so it'll be very cheap to do. But the problem there is it might become overprescribed. I don't think people like doing vaginal progesterone. It's unpleasant.
We
and
don't want to
uncomfortable
do
and
that.
Irritating.
No, yeah.
Of course, if it will help avoid a miscarriage,
I'll do
people
anything.
will stand on the head and whistle Dixie for 6 hours at a time.
Yeah, I mean, I didn't wear
Anything.
high heels for 9 months because an
Exactly.
acupuncturist told me that would tilt my pelvis and I'd lose the baby. I would never, ever do that now, but
Yes.
after 2 back-to-back losses,
I know.
that was my mindset.
You listen to everything.
Yes.
And there's a lot out there. One of the problems that you're helpful with, because your service is evidence-based and gives good advice. There's so much poor advice
Yeah.
out there. If people go to AI or go to Google, it's going to tell you all kinds of weird stuff, like not wearing high heels for 9
Yes.
months. It's amazing the species survived through the 60s and 70s, isn't it?
Yeah, it really is because, yeah.
So, no, progesterone, yes, is helpful for some, but you really do have to be careful who uses it. And annoyingly, and from a medical perspective, it is annoying that we can't give a good answer to most people who lose a baby like that.
Yeah. But I do think it'll change. I think that because the
we're getting
pervasive
there.
acceptance and that era of telling women it's common,
Yes.
it's genetics, it happens, it's kind of dying
Yeah.
in a really great way.
Yeah.
That what I'm seeing is a trend towards government also funding more research
Yeah.
in this space.
Yeah.
And then it starts there because then we have the strong data and the evidence that says, hey, this is what's needed here.
Yeah.
I know that I'm really excited by a number of projects at the moment that are happening. And they might be long term. We might be looking at 10, 15 years before that change. But you have to start somewhere, right? We have to kind of do that now.
I mean, I've had a great career as a clinical academic. I've done some, fairly pleasing bits of research that have, in some ways, made a difference. I wish I was starting now. I really do, because the scientific tools, the tech that we
Yes.
have, is just magnificent. And I go back to when I started, and the people teaching me to do medical research were at the top, the people I worked with, and I was always very impressed. But quite quickly, you sort of moved further along the track than they were able to keep up with. And I'm the same now. People beginning to really, I know we all go back to it, but AI is just making such a huge difference. And you'll take the databases of national databases from well-run miscarriage services, feed it all into an AI, and it'll pause, and it'll eat the power for New York for 3 minutes, and then it'll come out with an answer. And it'll change things. And that will happen within a decade.
100%.
Yeah.
It will. It will.
I can tell you what it won't be.
What won't it be?
Lifestyle. If we could do one thing, it's persuading people that they don't have to enter a nunnery or a monastery in order to have a healthy baby, because I think people are taking it too far these days.
Yeah.
And yes, be healthy, of course that's wise in all kinds of ways. But in a way, being overly paranoid about health is as harmful as not caring at all.
Yeah, and I often, I can use my own experience here, and I don't share this part publicly very often, but when I'd had 2 back-to-back losses, and at that point you weren't eligible for testing because 2 wasn't defined as recurrent, and so I went down the naturopath route, and I, as much as I got healthy, but I became very obsessed with what I would eat, what I couldn't eat. It became very restrictive. And yes, I then went on and I had a healthy baby. However, I then went on and had another loss. And then I had another baby, Rosie, the scan. And I didn't follow the same protocol for Rosie. And I'm one person, right? So that's not an evidence base at all. But I do know just personally, and from stories I hear from other women as well, that restrictive nature, that could have ended in a really dangerous place. And it wasn't a magic pill, but I'm going back to a moment in time when you are so vulnerable, to my point earlier about the heels. I was willing to do anything just to carry a baby to term and have that baby in my arms. And I think it's really important that organisations like Pink Elephants are evidence-based and don't provide health promotion information, because that's not our role. We are the early intervention support. Because otherwise there is too many people and it's too dangerous a narrative. If this magic thing will be the thing.
I know, if only you'd done this, and it hurts people. And so much of it doesn't have a good evidence base, and most of the things that you see on TikTok or Instagram are just, I don't know, people fantasizing about what might help, and then people take it really seriously.
Misinformation, right? 100%. No. So if anyone's listening today and they've been through their own experience or they're in the trenches now, what's the advice?
Be aware that you're not alone. Sharing when there's a big emotional burden, I think, is almost always a good thing. And be aware that there are compassionate and smart people who are there to help because they felt it and they didn't like it and they didn't have much help. So I think, a burden shared is a burden halved, and I really do think in this context, Sam, it's really good advice. If you're not sleeping, if you're worrying about this 24 hours a day, if your relationship is suffering, if your partner or your mum and dad are worrying about you because you're not mentally healthy, come on, in our time, people are not going to suffer in silence. And that has to be an improvement on the way things were in the past.
100%. And I can't think of a better way to close. That you're not alone, that you should reach out for support, and there is support for you.
Exactly.
Thank you so much.
That's been a pleasure.
That was amazing. Thank you.